What's up, YouTube, and welcome to my very first live stream. This is something that I have wanted to do for a few years now, and today is the day. Today, we're going to be talking about anesthesia medications and how they work. And so, we're going to cover basically the IV induction medications. So, in 2 weeks, I have a mock board exam. So, hopefully, this is going to help me study for that mock board exam. So let's dive right into it. The first medication that I want to talk to you about today is propofol. So propofol is super common. It is an induction medication. It's a general anesthetic. It's something that you will use pretty much every single day in the OR, but also something that you'll use pretty much every single day in really any critical care environment. So those of you ICU nurses, you probably use propofol literally every day for sedation on your patients. So propofol, the class is an alkyl phenol. It is a direct GABA agonist, meaning that it is going to open that GABA A ion channel, and it's going to increase chloride conductance into the cell. And whenever you increase chloride conductance into the cell, if you remember from basic chemistry, chloride has a negative charge. And so whenever you increase that chloride conductance, that is going to hyperpolarize the neuron, and it's basically just going to shut everything off, and there's going to be like a hypnotic state that's brought on by that. So just remember that propofol causes neuronal hyperpolarization. The induction dose is 1.5 to 2.5 milligrams per kilo IV. And so usually in anesthesia, we use about 2 per kilo IV. And that really depends. So if you have a very obese, heavy patient, you may use a little more. If you have a kid, kids are going to burn through anesthetic faster than adults will. You'll use a little more there. If you have like a frail old person, you're probably not going to use 2 per kilo IV. And again, this is really going to depend on the other medications that you're giving in addition to the propofol. So typically we will give like fentanyl or something to blunt the sympathetic nervous system response to laryngoscopy, and then we'll give the propofol. So by having that synergistic or that additive effect, you can give lower doses of propofol. But again, so for the bigger person and for this tiny child, you're going to give more propofol. But for like the older adult or somebody with some sort of cardiac abnormality, ischemic heart disease, that you don't want wild swings in hemodynamics, you're probably going to give a little less. So the onset of this medication is going to be around 30 to 60 seconds, and it's going to last for about 5 to 10 minutes. And it's cleared by the liver. So the P450 enzymes in the liver, plus a little bit of extrahepatic metabolism. And so with this particular medication, the extrahepatic clearance is going to occur in the lung. So cardiovascular effects, as we're talking about side effects, you're going to see some decreased blood pressure. And that's mainly going to be due to decreased sympathetic tone. That's going to lead to vasodilation and myocardial depression. So just remember that propofol is a direct myocardial depressant. It's going to decrease SVR, so systemic vascular resistance. It's also going to decrease your venous tone. And when you decrease venous tone, you're going to have decreased preload. And like we said just a moment ago, it's going to decrease that myocardial contractility as well. Respiratory side effects, it's going to shift the CO2 response curve down and to the right. And so that's basically going to make the body less sensitive to CO2. And that's what's going to cause that respiratory depression and or apnea. And it's also going to inhibit the hypoxic ventilatory drive, meaning that the patient is going to tolerate more CO2 than they normally would if they weren't on propofol. So that's what stops the breathing. So they're able to tolerate more and more CO2 until ultimately they become apneic if you give a large enough dose. And again, that's very dose dependent as well. If you give somebody like 10 milligrams or 20 milligrams of propofol, they're probably not going to go apneic. If you give a induction dose of propofol, so 2 mg per kg, they're certainly going to go apneic. CNS side effects, you're going to see decreased cerebral oxygen consumption. That's the CMRO2, and that's basically the cerebral metabolic rate that's going on in the brain. And so it's going to be decreased by giving propofol. You're also going to decrease cerebral blood flow, decrease intracranial pressure, and decrease intraocular pressure. All of those things are pretty good for the patient that has like traumatic brain injury or some sort of neurocranial issue going on. So neurocranial anesthesia works well for that. It's also good to know that propofol does not provide analgesia. So if you are needing an analgesic for whatever reason, make sure and give that in addition, because propofol is not really going to cut it there. It also has anticonvulsant properties. So it causes burst suppression on the EEG. And then you may also see myoclonus, which is like some twitching or jerking, not a true seizure, but it's called myoclonus. Other properties of propofol that are quite interesting is it does have some antioxidant properties, meaning that is a free radical scavenger. And then propofol infusions can also change the color of urine. And if you've worked in ICU long enough, you may see this. It can turn the urine green, and that's due to the phenol excretion. It can also cause cloudy urine, which is due to the increased uric acid excretion. And again, these aren't really things that you are going to be seeing in the OR. These are more like people that are on drips for greater than 48 hours that you might see some of these weird side effects. Okay, our next drug that we're going to talk about is ketamine. So, ketamine is an NMDA receptor antagonist, and it antagonizes glutamate. It's a general anesthetic, and it causes hypnosis. And so, if you remember from physiology, the NMDA receptor is agonized by glutamate. And so, whenever you antagonize glutamate, you're going to block that NMDA receptor. Ketamine is quite interesting because it doesn't only act on the NMDA receptor, it also has quite a few secondary receptor sites, and those include the opioid receptor sites, MAO, serotonin, norepinephrine, muscarinic, and sodium channels. So, ketamine really hits in a variety of areas. And as I said earlier, it causes a dissociation. And so it's really going to dissociate the thalamus, which is the sensory part of the brain, from the limbic system or the awareness part of the brain. And so it's more of like the lights are on, but nobody's home. And if you've ever seen ketamine given, you really get that sense that whenever you push ketamine, people just kind of like look like, they're there, they're breathing, but they're not there. And we'll get to the side effects here in just a moment as far as breathing and the respiratory issues. The induction dose of ketamine is 1 to 2 milligrams per kilo. If you're doing a ketamine drip or like a maintenance dose, which is really not that common, you're going to do 1 to 3 milligrams per minute. If you're giving an infusion dose, like a low dose infusion for, say, like opioid sparing analgesia, you're going to do 1 to 3 mics per kilo per minute. And then as like a bolus dose, you can do 0.1 to 0.5 milligrams per kilo IV. And so that's one of the cool things about ketamine is it does have analgesic properties. There are IM and PO dosing. I don't really know those off the top of my head. It's not something that we do super commonly. Mainly these drugs are going to be given IV. The onset is going to be about 30 to 60 seconds, and it's going to last about 10 to 20 minutes. However, after that 20-minute period, it may require like 60 to 90 minutes to really come back to baseline and to get back to that full like orientation that the patient was at to begin with. So ketamine is metabolized by the liver in the P450 enzymes. So chronic ketamine use will induce the enzyme that metabolizes it, meaning that the more medication you give, the more enzyme that breaks it down will be present. And so it's going to require, you're going to require escalating doses. If this is somebody that, say, like gets ketamine infusions weekly or for depression or something like that. And so that's another thing to mention is that outside of the OR, ketamine is used for chronic depression, for PTSD, for chronic pain. There's like a wide range of uses for ketamine, but obviously for this particular video, we're talking about induction in the OR. So side effect wise, cardiovascular side effects, you're going to see increased SNS tone, so increased sympathetic tone. And this is really useful for a patient who is hemodynamically unstable because it's going to increase the heart rate, it's going to increase the blood pressure, everything is going to go up. However, it is really important to remember that ketamine is actually a myocardial depressant. And so to get that sympathetic response, you are going to have an intact sympathetic nervous system. So if this is like a super healthy person, there's really no concerns there. However, if this is like some old septic lady or some old septic man who doesn't have good catecholamine stores, then that's when you really begin to think about the myocardial depressant effects of ketamine. You're not going to see that increased SNS tone, usually in somebody who's super sick, who have exhausted their catecholamine stores due to whatever pathology they have. But overall, you're going to see an increased cardiac output in the healthy patient, increased cardiac output, increased heart rate, increased SVR. You're also going to see an increase in the pulmonary vascular resistance. But as we said earlier, it's a myocardial depressant. So just have that in mind if you have like super unstable patients. Respiratory effects, it's a bronchodilator. So a very good choice if your patient has asthma or is actively wheezing. It's a very good medication to help with that. The upper airway muscle tone and the airway reflexes will remain intact, which is really nice because as soon as you give ketamine, the patient is out, but they're still breathing. And so it doesn't really do anything with the airway. You're going to maintain the respiratory drive. There may be like brief periods of apnea, but overall, from my experience and from what I've seen in textbooks, ketamine, you're going to maintain your airway and you're going to continue breathing. So it doesn't significantly shift the CO2 response curve. As we said in propofol, it shifts it down into the right there, inhibiting the hypoxic ventilatory drive. But with ketamine, not really going to do much by way of respiratory depression. However, you will see increased pulmonary secretions. And so you will have just lots of secretions coming out, especially at higher doses, escalating doses. So if you give the 2 milligrams per kilo as an induction dose, you're going to see secretions. So either suction or you can give glycopyrrolate. So glyco is an antimuscarinic, and so it's going to help combat some of those muscarinic side effects that we really want to stay away from, especially if we have respiratory patients and all of a sudden we give our ketamine and they're like not drowning in secretions, but there's a lot of secretions present. You want to either suction that or pre-treat with glyco. CNS side effects, you're going to increase the cerebral metabolic rate of oxygen consumption, increase blood flow to the brain, increased intracranial pressure, and increased EEG activity. So you kind of want to caution that if there's a history of seizures. Ketamine may or may not increase intraocular pressure, but it can cause what we call a rotary nystagmus, and that's where the eye like twists around. So whenever we think of rotary, it's more of like a twisting. Whenever you think of a horizontal nystagmus, that's the beating side to side. So it can cause some weird stuff with the eyes. Another untoward side effect can be the emergence delirium. And so that really presents as nightmares and hallucination. That can persist really up to 24 hours. Textbooks say that benzos are really the best way to prevent that, to pre-treat with a benzo. Risk factors for that emergence delirium are really anybody older than 15 years of age, female gender, and if you're giving very big doses of ketamine, you could see the emergence delirium as well. Personally, in my experience, I haven't seen emergence delirium. I don't have that much experience with ketamine. I've used it a bit in my emergency medicine career, but not quite that much. So for the analgesia, as we mentioned earlier, we're going to kind of give this a little separate spiel here as far as the analgesia side effects of ketamine. It does provide good analgesia, opioid sparing effects, and it's really the only induction agent that does this. It relieves somatic pain greater than visceral pain. And so when you think of visceral pain, that's more of intra-abdominal, so pain from the viscera, the intestine, the liver, things like that. Somatic pain is going to be more like you cut yourself and you have an open laceration. So it's going to help with that pain more than it will the visceral pain. It's going to block central sensitization and wind up in the dorsal horn of the spinal cord. It's going to prevent opioid-induced hyperalgesia. And then the analgesic properties really make it good for burn patients. Frequent dressing changes, really any kind of chronic pain syndrome is going to be very good. And that's been my experience in emergency medicine, as I've used it quite frequently for people that come up with chronic pain, especially in the departments where we're trying to go opioid-free. So that's a bit about ketamine. And now we're going to move on to etomidate. So etomidate is an imidazole, and that basically means it is a ring in the chemical structure. And so at acidic pH, that imidazole ring is going to open up and it's going to increase the water solubility of the medication. But then at physiologic pH, so when you inject the medicine into the body, that imidazole ring is going to close, and that's going to increase the lipid solubility of the medication. So etomidate is a GABA agonist. Much like propofol, it's going to open that GABA channel. It's going to increase chloride conductance into the cell. That's going to hyperpolarize the neuron and really shut everything off up top. It's going to onset within about 30 to 60 seconds, and it's going to last about 5 to 15 minutes. It is metabolized in the liver by the P450 enzymes and by plasma esterases. And the rapid awakening that you get due to etomidate is due to redistribution and not metabolism. And I think that takes a little bit of explaining. So redistribution is whenever you initially give the medication goes to what we call the vessel-rich group, so the heart, the lungs, the brain, where the majority of the cardiac output is going. And the rapid awakening that you get from that, so again, lasting 5 to 15 minutes, the rapid awakening that you get from that is the medication distributing out to the tissue and not causing an effect in the brain anymore. And it's not due to metabolism. So metabolism takes a little bit longer, but the actual awakening is due to redistribution. Etomidate is going to be a really good medication for the hemodynamically unstable patient. And so a key benefit is the hemodynamic stability that it provides. So you're going to see minimal changes in heart rate, stroke volume, cardiac output. SVR is going to be mildly decreased. So you could potentially see a small reduction in blood pressure, but not to the effect that you would with, say, propofol. If you give like 200 milligrams of propofol as an induction dose versus 30 milligrams of etomidate, you're going to see wild changes with propofol if you have an unstable patient, and not so much with the etomidate in a stable patient. Respiratory effects, you are going to see mild respiratory depression, but it's going to be less than propofol. CNS effects, you're going to decrease the cerebral metabolic oxygen consumption, so the CMRO2, decrease cerebral blood flow, decrease intracranial pressure. The cerebral perfusion pressure remains the same, and then there's not going to be analgesia. And so the dose, I don't think we hit on the dose earlier, but the dose is going to be 0.2 to 0.4 mg per kg IV. And yeah, that's really about it on etomidate. So etomidate, in my experience, is something that I've used for pretty much all of my rapid sequence inductions, either etomidate or ketamine. Going back to talking about propofol, it's super common for anesthesia folk to use propofol in the induction. I haven't started my clinical sequence yet. I start that in a few weeks, but it'll be interesting to see what medications are used for induction. I feel like outside of the OR, in like critical care environments, so ER, ICU, things like that, I feel like most providers kind of gravitate towards etomidate and not so much the propofol. But again, that's just my observation. So some more things to note about etomidate. You can have myoclonus. So myoclonus is really described as the involuntary skeletal muscle contraction, dystonia, or tremor. And you can see that, as we said earlier, with propofol, not super common, but it's really important to note that it's not a seizure. And so myoclonus and seizure are not the same thing. However, with etomidate, in a patient that has a history of seizures, etomidate will increase the risk of having a seizure. Now, if you don't have a seizure, or if you don't have a seizure disorder, so you have a patient, they're totally healthy, no history of seizures, etomidate will not increase the risk of seizures. But one of the, I guess, two of the important side effects of etomidate, and something that I think is probably more textbook than clinical practice, is that etomidate can inhibit cortisol and aldosterone synthesis. And again, I don't know that this is something that is super clinically relevant. I think it's clinically relevant in the fact that when you intubate, you give a one-time dose of etomidate. You don't start somebody on an etomidate drip. And I think it's for this very reason, because it can cause adrenocorticosuppression. And it does that by inhibiting the 11-beta hydroxylase enzyme. And that will basically inhibit the production of cortisol and aldosterone for about 24 hours. And so if you have somebody that's super sick and septic or whatever pathology they have, and you're like, give them a one-time dose, probably not that big of a deal. But you put them on a drip, and you're constantly inhibiting their adrenal gland production, then you're probably going to be dealing with more problems that you want. So again, that's probably not super clinically relevant for like a one-time push dose, but that's why we don't do etomidate drips, is for that very reason, the adrenocorticosuppression. Etomidate causes postoperative nausea and vomiting, and is actually the most common agent that produces the postoperative nausea and vomiting. It can be as high as like 30 to 40%. So again, maybe a reason that we don't use etomidate super often is because usually in the OR, we're like, putting people to sleep and waking them up and either keeping them for a few days in the hospital or sending them home. I do understand that some cases you're going to leave the patient intubated and send them to the ICU or whatever, but and it's going to depend on where you work, but you are going to be waking up at least some patients, hopefully not all of the patients. Some, like I said, some patients may go to the ICU intubated, but you're going to be waking up patients and getting them ready to be discharged home. And so etomidate is less of a nice choice in somebody that's going to be waking up because you don't want them waking up and like vomiting everywhere. So I can see why that people would choose, say, propofol over etomidate in those types of settings. Again, if you're like sending the patient back to the unit intubated, not a big deal. But if you're going to be waking them up and sending them home, definitely consider the post-op nausea and vomiting. And there are medications that you can use to treat that, but there is a high incidence. The next medication we're going to talk about is dexmedetomidine, also known as Precedex. So a very interesting medication and something that you probably use in the ICU for sedation. Not super common to, really not common at all to use for induction, but it is a good adjunct agent to use during your anesthetic. It really helps for smooth wake-ups during emergence and extubation. The class is an imidazole ring. And so we talked about that with etomidate. So the imidazole ring is going to close, I can't remember now, I think it closes at acidic pH. It opens at acidic pH, closes at physiologic pH, making it more lipid soluble. It's an alpha-2 agonist, which the alpha-2 agonist pathology, or the alpha-2 agonist physiology is super interesting if you're not familiar with that. But basically, it's going to decrease cyclic AMP production, and it's going to inhibit the locus coeruleus in the pons, and that's going to lead to sedation. The loading dose is going to be about 1 mic per kilo over 10 minutes, and then the maintenance infusion is 0.4 to 0.7 mics per kilo per hour. With a loading dose, you're going to see an onset in about 10 to 20 minutes. After the infusion has stopped, then you'll see the medication wearing off in about 10 to 30 minutes or so, really depending on the dose that you give. It is metabolized by the liver, the P450 enzymes. But as we said earlier, I do kind of want to hit on the mechanism of action a little bit more. The dexmedetomidine is quite unique because the sedation comes from presynaptic alpha-2 stimulation in the CNS. And so whenever you are stimulating the alpha-2 receptor centrally, we're not talking about peripherally, but centrally in the brain and the spinal cord, is going to decrease cyclic AMP production. And when you decrease cyclic AMP production, you're going to decrease the sympathetic outflow from that particular nerve, so decrease norepinephrine, and that's going to lead to that sedation and the analgesia. It's very interesting, though, because rapid administration of dexmedetomidine can cause hypertension. We'll get to the other side effects here in just a moment, but keep that in mind, that rapid administration, so like a super fast push, will cause hypertension because of alpha-2 stimulation in the vasculature. And so whenever we think of centrally acting alpha-2s, so like Precedex, clonidine, things like that, its main action is going to be in the CNS and not in the peripheral vascular system. However, you give it super fast, it's going to saturate those peripheral receptors first before it gets to the brain, and it's going to cause some transient hypertension. But as you probably know, if you use this at all in the ICU, hypotension, bradycardia are some of the main side effects of dexmedetomidine. It does not cause respiratory depression, respiratory side effect wise, and that makes it a very attractive thing for procedural sedation or difficult airway management. And so I'll tell you, the way we use this in anesthesia is for smooth wake-ups. So during emergence and extubation, it really helps things go smoothly. And then for difficult airway management, so if you're doing like an awake fiber optic intubation, Dex is a really good option to not make your patient stop breathing, but get them like sleepy and sedated a little bit. And so you're going to see no change in oxygenation, there's no change in blood pH, and then there's no change in the slope of that CO2 response curve that we talked about earlier. You are going to see decreased cerebral blood flow. There's not going to really be a change in the cerebral metabolic rate of oxygen consumption, so the CMRO2. There's also no change in the ICP. And then dexmedetomidine is unique because it produces sedation that resembles natural sleep, which is, I find, super interesting. But sedation is the result of decreased SNS tone and reduced level of arousal. So going back to that decreased cyclic AMP response. Patients are going to be easily aroused, but then they go right back to sleep when stimulation ends. And so if you've, again, worked in the ICU, you know that you go and stimulate the patient. If they're on a reasonable dose of Dex, they'll wake right up, but then they'll go right back to sleep when you stop messing with them. It does not provide reliable amnesia. And so really none of these medications we've talked about so far provide amnesia. So if you're needing an amnestic to make the patient forget something that's currently happening, then you need to consider that as well. Dexmedetomidine impairs the thermoregulatory response, and so it's going to produce an anti-shivering effect. So patients who should shiver don't shiver, is, I guess, another way of saying that. It reduces the incidence of emergence delirium in children. And then analgesia is another really cool property of dexmedetomidine. And so much like ketamine, it has a few different properties, analgesia being one. And that's produced by alpha-2 stimulation in the dorsal horn of the spinal cord. And so that's going to decrease substance P and decrease glutamate, both of which neurotransmitters can or play a role in pain transmission. It does not impair evoked potentials. We haven't really talked about that much, but evoked potentials are basically if you're in the OR, you're doing a case, usually on the spine surgery, something neurological, neurocranial. There will be evoked potentials monitored, and that's basically monitoring the integrity of the spinal cord. And there are certain medications that mess with those monitors, and dexmedetomidine is not one of those, so you can use that. It's also useful for what we call a wake-up test. So if you're doing spine surgery or scoliosis surgery, something of that nature, where you need to monitor and make sure the patient hasn't, lost all of their neurologic function due to the surgery, you can like shut the drip off, wake them up really quick, make sure they can move everything, and then send them back to sleep. And then there are also nasal and buccal routes of this medication as well. There are also some oral forms. It's not called Precedex, but there are centrally acting alpha-2 agonists that act orally as well. All right, our last one, benzodiazepines. And this is really going to encompass things like midazolam, diazepam, lorazepam, things like that. And these aren't, again, super common for induction. You could probably give a big enough dose that you could induce somebody with that, but we don't use like midazolam or really any benzo as like a sole induction agent. We do give benzos preoperatively to decrease like situational anxiety and to kind of like bring the patient down. So again, not everybody gets a benzo, but it's something that we do give sometimes. So I think it's worth mentioning. And the class is benzodiazepine, as we just said. It is an imidazole ring. So going back to ketamine and dex, same type of thing. At acidic pH, the imidazole ring is going to open, increasing water solubility. At physiologic pH, the imidazole ring closes, and that's going to increase lipid solubility. Mechanism of action is a GABA agonist. So pretty much, with the exception of like dexmedetomidine and ketamine, all of the induction agents are GABA agonists. So that GABA ion channel is going to open, and that's going to increase the chloride conductance. However, it is worthy of noting with this particular medication that, or this class of medication, that benzodiazepines cause an increased frequency of channel opening. And I think that's an important distinction because the other medications like propofol, it's going to increase the duration that the channel is open. And so more chloride is going to come in. However, with benzos, it's going to increase the frequency of the channel opening, meaning the channel will open more frequently. Same way of going about saying that more chloride is going into the cell, and that's going to lead to the neuronal hyperpolarization. As we just said, most of the GABA agonists increase the channel time, but benzos increase the channel frequency. IV sedation, 0.01 to 0.1 mg per kg. If you're doing PO, like for kids, 0.5 to 1 mg per kg. If the kid doesn't already have an IV, then you can do PO dosing. For kids, we typically do like an inhalation induction and then start the line after they're already induced. But again, it depends on if the kid has an IV or not. It's going to onset within 30 to 60 seconds. It's going to last about 20 to 60 minutes. This depends on the medication that you're using. So midazolam is going to be shorter acting. Diazepam is going to be very long acting. Lorazepam is going to be a little less long acting than diazepam. But again, it's going to depend on the particular type of benzo that you're using. They're eliminated from the body by the liver, the P450 enzymes, and there is an active metabolite. And so this is kind of important to mention. With pain medications, particularly opioid medications, and then benzos, there are what we call active metabolites. And that is once the liver or the kidney or whatever part of the body is breaking down the substance, usually the liver, the next product that's formed in that breakdown is called a metabolite. And most medications, I don't really know that most, but some medications have what we call an active metabolite, meaning that medication is still physiologically active and can cause a response. And then some have an inactive metabolite, meaning that the metabolite's there, but it's not exerting any effect. And so this is one of the cases where there is an active metabolite, and it's called 1-hydroxymidazolam. And that particular molecule or substance is half the potency of midazolam. And it's rapidly conjugated to an inactive compound. However, in the renal failure patient, you're going to have a buildup of that 1-hydroxymidazolam. So renal failure patients, just be careful with benzo dosing because you may give them like 5 milligrams, and that's going to last a really, really, really long time whereas a normal person, it may last an hour, a couple hours, or something like that. But in a renal failure patient who can't excrete that active metabolite that has been created, it's just going to hang around and exert more side effect. And that kind of leads us into the side effects. So side effects, you're really going to have minimal effects. If you're giving a big induction dose, you're going to have decreased blood pressure and decreased SVR. However, if you're giving the like 2 to 5 milligrams just for anxiolysis, there's not really many side effects to be worried about. At sedation doses for respiratory effects, really minimal. And at induction doses, you're going to see respiratory depression. Opioids given with a benzo, as you probably already know, are going to potentiate the respiratory side effects, even at doses used for sedation. So if you give like 100 or 200 of fentanyl, and then you follow that up with 5 of midazolam, then that respiratory depression is going to be significantly increased than if you just gave one or the other. And you really want to watch out with this with patients that have like COPD or some kind of lung abnormality or something that's going to decrease their ventilatory drive. And so they're going to be especially sensitive to those respiratory depressant medications. So just have some awareness in that. And at least from my experience, patients with like chronic COPD and they're on oxygen, all that, they're not getting benzos preoperatively. These are mainly for like healthy patients or patients that don't have kidney disease and are on dialysis and things like that. CNS side effects, there are really minimal effects on the CMRO2 and the cerebral blood flow. At induction doses, you're going to see a decreased CMRO2 and a decreased cerebral blood flow. It cannot produce an isoelectric EEG, whereas propofol can. It's going to cause anterograde amnesia, and it's not important to note, it's not going to cause retrograde amnesia, meaning that if you give the medication, it's not going to make them forget something that happened before the administration. But if you give them like 5 of midazolam and they had a wake up during intraoperatively, the patient woke up or was like lightly sedated and they're opening their eyes, they're not going to remember that. So that's the anterograde amnesia that we speak of, not retrograde amnesia. It is an anticonvulsant, it's an anxiolytic. It causes spinally mediated skeletal muscle relaxation, so an antispasmodic. So it's useful in patients with some sort of CNS disease like cerebral palsy or something that causes major muscular issues. Outpatient-wise, again, not necessarily in the OR, it can cause like muscle relaxation. You can use it for muscle spasm, things like that. But important to note, it does not provide analgesia. Apart from ketamine and dexmedetomidine, really none of the induction agents provide analgesia. Okay, now we're going to talk about a few of the others. So diazepam, again, still a benzo. It's going to undergo enterohepatic recirculation, which means that it's going to go through the liver several times before it is eliminated. And so the half-life of diazepam is going to be about 43 hours, very, very long time, which if you've worked in other areas of medicine, like emergency medicine, where patients come in with seizures and they get rectal diazepam, the reason that that medication is used is because it lasts so long, 40-something hours. Like if that dose hangs around for 40-something hours, low likelihood that they're going to re-seize unless something else is going on. They could, I've seen it, but not super common. It can be used as an anticonvulsant, and it can also be used to prevent emergence delirium following ketamine. As we talked about, it's also used as an antispasmodic agent. And then we're going to move on to lorazepam. So lorazepam's amnestic action can last up to about 6 hours. It has a slow onset, which really limits its usefulness as an anticonvulsant. The relative potency, though, is something that I feel like we're tested on frequently, and that is like within the benzodiazepine category, what's the most potent one, what's the least potent, and arranging them in that order. So in that order, lorazepam is going to be the most potent, followed by midazolam, followed by diazepam. And as we said earlier, they provide anterograde amnesia, not retrograde. And it's also important to note that propylene glycol is added to diazepam and lorazepam to enhance their water solubility, but that additive can cause venous irritation. And so if you've given diazepam or lorazepam, patients kind of complain of the burning sensation, and it's due to that propylene glycol that is added to the medication. And that's it on benzos. So those are all really of the induction agents that I have for you. There are other induction agents like the barbiturates. However, they're not super common. They're not medications that we give super frequently. And so I feel like they're probably not that worthy of hitting on right now. They are testable material for me in our anesthesia program, but it's just not something that I feel like we use super frequently. So I'm not going to dive into that right now. But if you guys have questions, pop them in the chat. I would love to answer. And if not, then I will see you next time. Thanks for watching the live stream, and after the live stream's over, send a comment below. Let me know if this is something you enjoyed or something you found helpful. I would certainly consider doing more of them in the future. If not, then I will see you next time.